we had now a few minutes to load the presentation of Dr. Groesbeck Parham. So you are coming from the African Center of Excellence for Women's Cancer Control. And I am sure that your talk now will be as stimulating as the two previous ones.
I hope so. Thank you very much. I've been asked to say a few words on viable service delivery platforms or alternative platforms for screening or cervical cancer prevention in very resource-constrained environments. I work in Zambia as the co-director of the Cervical Cancer Prevention Program. I've been there since 2005. We've screened over 100,000 women for cervical cancer. A third of those are HIV positive, and we use this approach called screen and treat, where we just put vinegar on the cervix and, depending on how the lesion looks, either perform cryotherapy or excise it with LEAP. So the central issue here, in my mind, is that there's a huge gap between scientific, clinical, and public health discovery as it relates to cervical cancer prevention and the real implementation of service delivery in these resource-constrained environments where disease burden is greatest. In Central, Eastern, Southern Africa, there's a corridor of countries there: Kenya, Uganda, Tanzania, Mozambique, Zambia, that have some of the highest cervical cancer incidence rates in the world. And then you go to Guinea, Cameroon, where it's also very high. Zambia has the second highest cervical cancer incidence rates in the world, following those in Guinea. So we're talking about trying to implement these scientific discoveries where it's going to make a significant difference, where the disease burden is greatest. Now, if you look at the cervical cancer care infrastructure gaps in sub-Saharan Africa, and that's all the way from advocacy, screening, to treatment, this is what you find. There's very little, if any, laboratory capacity. In Zambia, when I first arrived in 2005, there was not one certified cytologist in the country, and that still exists today. That we have 2 pathologists that work for the public sector throughout the continent. As you move around in universities and in centers that perform cervical cancer screening, there's a tremendous paucity of laboratory capacity, the inability to perform histology, shortage of glass slides, H&E stain, wax, and certainly a real problem with timely reporting. There are also issues with diagnostic capability. When you start moving out into rural areas outside of cities, what you find in these provincial health centers is that there's an absence of vaginal speculums, or what you may call couscous, which is why sometimes physicians and nurses and healthcare providers don't perform pelvic examinations. And in these environments, there's data to suggest that greater than 90–95% of women have never had a pelvic exam, and these are some of the reasons why. There are no speculums, there's no biopsy equipment, there's not even formalin or the bottles in which to place formalin to put a tissue specimen, very few pathologists, and no colposcopists to even speak of, let alone a colposcope, right? And then you get down to this thing called the treatment infrastructure, where there's a paucity of surgeons. If there are anesthesiologists, sometimes the quality is lacking. When you find cases of early invasive cancer and you try to get these patients into the surgical theaters, it's difficult to do it sometimes because of operating room time. The facilities and the people are just not there. So patients end up coming back 2 or 3 times, and then in some instances they disappear and never come back. Then there's a big problem that no one really talks about, which is the absence of management systems. There are no algorithms. There's no quality assurance. There's an absence of a supply chain and any semblance of anything called procurement to acquire, to preserve, and to disperse supplies when they're needed. And then there's this whole issue of recall, referral, and management mechanisms, and then the absence of advocacy and leadership. So across the spectrum, I think, this is the way the cervical cancer infrastructure looks throughout most of sub-Saharan Africa. Maybe there's some unique spots such in Cape Town and maybe in Johannesburg, but by and large, this is the way it looks. So then the central question is, how can we implement effective secondary prevention service delivery platforms? This is a term I just stole from my good friend Sankar, service delivery platforms, in these environments. How can we implement effective secondary prevention or screening and treatment, cervical service delivery platforms in these environments? Is it possible? So let's take the traditional approach, which my colleague recently just described. It's called screen, diagnose, confirm, and treat. You screen a patient with a pap smear if it's abnormal, if it's high-grade disease. You diagnose it with colposcopy. You take several biopsies, and then you get the results back, and then that's confirmed with histology. And then you, depending on the grade of the disease, you perform cryosurgery and LEEP. In most Western nations, it's LEEP. That's a minimum of 3 visits. And we know that as we increase the number of visits that a woman has to endure before she finally gets to treatment, it decreases the chances that she will ever get the final treatment in these low-resource environments. Then there's this thing called the immediate approach, which is screen and treat. And before recently, it was visual inspection with acetic acid, and depending on the way the topography of the lesion appeared, a nurse or a healthcare provider would freeze that lesion with cryosurgery using either carbon dioxide gas or nitrous oxide gas, or remove it with electrical excision. Thank you. Now, since we have the emergence or final appearance of the CARE HPV, we can talk about screen and treat using HPV-based screening and treatment. So, again, is single visit if it's cryosurgery, or single or 2 visits if it's LEEP? Some people believe in performing C and LEEP. Now, so whether you have a positive HPV test, or whether you're using VIA and see something, or whether you're using visual inspection with acetic acid as the first test, or HPV testing and then it's positive, you're going to need to apply acetic acid, which is vinegar. And this is the sort of thing you're looking for, this white lesion with a sharp margin. And something like this would be amenable to cryotherapy. And that's just the effect of freezing the cervix. Something this large that occupies more than 75% of the transformation zone and goes up into the endocervical canal, you would need to remove it with outpatient electrical excision procedure, which we call LEEP. And that's the way it looks. And that specimen in the middle on the bottom is what's sent to pathology. There's a lot of evidence now to support the development of some type of optional secondary cervical cancer prevention service other than what my colleague just talked about, other than this traditional form of screen, diagnose with colposcopy, biopsy, screen, diagnose, biopsy, the one that requires 3 or 4 visits, cryotherapy, or LEEP. We know that VIA, we know the accuracy of VIA and HPV, and that HPV is a much more sensitive test. We know that cryosurgery is safe, acceptable, and that is feasible. We've been given data from randomized clinical trials on the effectiveness of HPV plus referral and VIA plus cryotherapy. and we know about the cost effectiveness of see and treat approaches. So this paper was one of the papers that I think turned the field on its head, led by our friend Dr. Sankar, which was a randomized clustered study which showed on the green line that HPV testing was more efficacious than VIA and cytology in decreasing the stage 2 disease and in decreasing mortality from invasive cervical cancer. Then we had this wonderful screen and treat study led by Dr. Lynn Denny and Louise Kahn down in Cape Town, South Africa, where they compared cryotherapy and treatment with cryotherapy combined with HPV, the HPV-based screen and treat with cryotherapy-based screen and treat. And it was shown that HPV testing was very effective in reducing CIN2 rates over a 3-year period of time in HIV positive and HIV negative women. Then there's an interesting little study that I found sort of tucked away in the literature from 2007, which was a hospital case series in Malawi between 1993 and 1998, performed during that time. And basically what they did was they took a health staff in the hospital and rural clinics and trained them over several months of period of time to improve their skills in early cancer detection, to stage disease, to recognize cervical cancer, and to stage it, clinically stage it, to go out into the community to raise public awareness through pamphlets, posters, and sensitization, and made it a part of their routine task to give a monthly health talk to their constituents, which totaled 1 million women. And this happened in 1993 and 94, and then they watched what happened, observed what happened to the stage of disease over that 5-year period of time. And what they found was that late stage cervical cancer prevention, stage 3 and stage 4, dropped from 70% in 1993 to 27% in 1998. Now, whether this transferred to lives saved, those patients would have to have undergone radical surgical treatment with either, like I said, with either surgery or radiation. So that's a possibility, and this is what they're looking for, just what we call downstaging disease, trying to find the disease before it has spread beyond the cervix. So I think there's data. I think the conditions demand in these low resource environments an alternative platform for cervical cancer prevention and treatment other than colposcopy, biopsy, pap smear, et cetera. And it has to be now HPV DNA-based screening, and if that doesn't exist, VIA-based screening. And however we put it together, it needs to be low cost, it needs to be done quickly, something that can be done quickly, simplistically, it needs to be fairly accurate, it needs to require minimal training, and needs to be amenable to task shifting. When I first got to Zambia, there were 10 gynecologists in the country. Now there are only 25, and you find that throughout the continent. Then whatever we do, we have to minimize the need for pathology. That subspecialty is in shortest supply across the continent than any of the others, and it takes years to train pathologists. So we have to find a way to get away from this traditional gold standard of judging what it is that we're looking at. So molecular testing is obviously what needs to be done, because you cannot reproduce pathologists. You cannot reproduce a pathology system in this part of the world. It just will not happen. Whatever we do, screening needs to be linked to immediate treatment. It needs to be linked as close as possible on the same day, if at all possible, to decrease loss to follow-up. The system needs to be rapidly scalable because we have a tremendous problem. There are suggestions from the World Health Organization that the rates of cervical cancer are going to rise in these parts of the world over the next 20 20 years. And we have to find a way to make it sustainable outside of the current donor model. That model is becoming ineffective. It is shrinking because of what's happening to the economies in the Western world, and we have to find a way to use business, some type of business innovations or incentives to make this system sustainable. Everybody has to be incentivized. Again, I would suggest that it has to be organic and multifaceted. One size doesn't fit all. It has to be adopted and led by local governments. You have to have an M&E system, and it has to be led by committed, passionate, ethical leaders. Thank you.